Good morning, good afternoon, and good evening to all of you. Thank you so much for joining us today for this IASC briefing on the interagency humanitarian evaluation and the COVID-19 response. I'd like to welcome you all and thank you again for making the time to join us. My name is Mervat Shilbaya and I am the head of the Interagency Standing Committee Secretariat, and I'm delighted to be facilitating today's briefing. I'm also equally delighted to be joined by representatives of the evaluation team who will be speaking to us on the key findings and recommendations from this evaluation, which looked at the collective IASC preparedness and response at the global, regional, and country levels to meet the humanitarian needs of people in the context of the COVID-19 pandemic. We will also hear firsthand accounts from the resident humanitarian coordinator in Colombia, as well as the CEO of Tamdeen Youth Foundation in Yemen, who have also kindly joined us. Thank you again for being part of the panel. And they will highlight the realities of the response on the ground, what worked well, where there were challenges, and some of the lessons in preparing for future outbreaks and pandemics. I'm also grateful that Kelly David, who is the chair of the Interagency Humanitarian Evaluation Steering Group, was able to join us today. Thank you so much, Kelly, for joining. And Kelly will be coming in later on during the briefing to share updates on upcoming evaluations. So colleagues, what is clear is that there was much that the humanitarian system was able to deliver to respond to this unprecedented crisis, from launching the first ever global humanitarian response plan in record time, to mobilizing significant funds at record speed during the first months since the declaration of the public health emergency of international concern, to the IASC under the leadership of the World Food Programme fielding the largest logistics operation to transport humanitarian supplies and passengers, to the issuance of much needed guidance, including guidance related to public health and social measures for COVID-19 preparedness and response in low capacity and humanitarian settings, to negotiations, vaccine negotiations, and reserving or making sure that there is a humanitarian buffer through the COVAX facility, among others. However, it was also clear, and this featured very strongly in the evaluation, that the crisis really put the spotlight and amplified some of the challenges that we're facing and have been facing as a system for quite some time, particularly when it comes to engaging, resourcing, and empowering local actors and local NGOs, as well as engaging and responding to community feedback and working through the nexus amongst others. So this briefing is really a critical opportunity to hear of these findings and capture lessons and recommendations that would not only equip us to respond to future pandemics, but also enable us to respond even better and in a strengthened way to current crises, take into account these important findings. So that, without further ado, I'm extremely pleased to turn to Andy Featherston, who is the evaluation team leader, as well as Tasneem Moji, senior evaluator, to share the key findings and recommendations. Over to you, Andy and Tasneem.
Great, thank you very much, Mervat. Thank you very much, everyone, for offering us an opportunity to discuss and talk through the findings of the evaluation of the COVID-19 humanitarian response. My name, as Mervat said, is Andy Featherstone, so I was the team leader. Tasneem worked closely with me as the senior evaluator. We've got a fairly short time to try and run through the key findings, but just before I do that, I think a quick note just on the scope of the evaluation, sort of looking across the response, both the sort of preparedness activities and the response over a period of 2 years, 2020 and 2021. As part of that, the evaluation spent about best part of 12 months looking across a range of contacts, as Mervat said, both at the global level, the regional level, and we visited Nairobi, the hub in Nairobi, and we visited 8 countries: Somalia, Sierra Leone, Bangladesh, DRC, Turkey for the refugee response, Colombia, Syria, and the Philippines. 6 of those 8 were in-country missions, and in all of those we had local evaluators who engaged with communities really to get their feedback. So as well as engaging folks in the humanitarian system, we've also went a significant distance trying to engage communities as well. And we talked about just over 1,100 folks to get their perceptions of the assistance that they received. Great. So I'm just going to go through the conclusions and the recommendations. So a health warning on this. The conclusions look across everything. The recommendations, because they're about pushing the system and looking at what needs to change, they do focus on some of the challenges and issues that didn't work. So bear that in mind as a health warning. I would flag, please have a read of the executive summary. It's a 20-page document and pretty digestible, and that gives a more sort of balanced view of the findings as well as the conclusions and recommendations. But given that we've got a short period of time, let's just start on the headline conclusions. So on to the next slide, please. Great, so 5 conclusions. So there's a big picture. So firstly, I think it's really important to say that this was the first global humanitarian response. So an extraordinary response, unprecedented in its scale and scope, and we stand by that. It was an extraordinary undertaking, something for which, and we'll talk about this a little bit later, that the humanitarian community, and to be fair, governments globally were really unprepared for. But in undertaking it, a significant push, both in terms of stretching resources, but also stretching capacity and really undertaking something that hadn't been done before. So quite extraordinary. Secondly, I think by way of feedback, it was imperfect. To some extent, most people said, well, it's always going to be imperfect because the needs far went beyond anything that the humanitarian system could respond to. Importantly, it went beyond what governments could undertake. The Global Humanitarian Response Plan, which was drafted within the weeks after the declaration by WHO, focused on 63 countries. Humanitarian needs increased by 45%, increased to 248 million people. So a massive scale up. Largely as a consequence, it was imperfect. There were huge challenges around movement, around priming the system, getting funding in place. So absolutely no question that it was imperfect. But what it did do and what the evaluation found, what came out very strongly, is that the humanitarian response provided a really important safety net for many millions of people. So a significant undertaking and a lot of reason to see the effectiveness of that. And I think as part of that, a lot of agencies went beyond what they're used to, went beyond their sort of tolerance and comfort zones. And I would say in particular, local and national organisations, as we'll remember, there were travel restrictions, lockdowns. And so what that did mean is that the international system, to a large extent, not completely, but to a large extent, withdrew somewhat. And local and national actors took a significant part of the strain, showing huge tenacity and courage and capability in doing that. What the response did do, and Mervat signalled some of these key issues, is it did shine a spotlight on a number of issues that we know as humanitarians working in this system that are challenges. It magnified those challenges many times over. So in a way, what it did do was to show some of these enduring challenges that the system has. And I think sort of linked to that, in terms of the evaluation team and our own sort of thoughts and thinking, certainly didn't necessarily show that the system wasn't fit for purpose. The policies are in place. We know how to respond, and a lot of and there was significant adaptations made in order to respond. But I think there is an important gap in terms of the policies on the one hand and our ability as humanitarians to practice them on the other. So work to do in terms of moving from policy to practice, and that's very much a focus of the recommendations. So now we'll jump into the recommendations on the next slide, please. So 5 groups of recommendations. So firstly, around affected people, the importance of putting affected people at the centre of a response. Secondly, around trying to have a more nuanced understanding of vulnerability and a need to prioritise, well, first understand who is in greatest need and consistently prioritise them in the response. Important cluster of recommendations around local actors, acknowledging the important work they did, but still conscious that there is more work that the system can do in terms of empowering, supporting, capacitating local actors to play their full role. Fourthly is around this nexus issue, important to build a coherent and cohesive system. Again, pulling together was absolutely essential in the COVID response. And then finally, as I mentioned, the COVID response really was a sort of high watermark for innovation and adaptation in the humanitarian community, and there's certainly a number of adaptations that offer important learning for us. So I'll go through each of these in a little bit more detail, but I'll try and continue fairly swiftly. So firstly, putting people at the centre of a response. So what did we conclude? Firstly, and this again wasn't necessarily a surprise, but by withdrawing to some extent as a consequence of the movement restrictions or travel restrictions, and even local actors oftentimes, not always, but oftentimes also faced restrictions in what they are able to do. It meant that humanitarian assistance lost some of its humanity. There was a greater gap between those providing aid, oftentimes, and those receiving it, and that made it difficult to do our job properly. As a consequence, there was a greater reliance on remote methodologies. On the one hand, that was interesting and good and offered lots of learning. On the other hand, it did mean that compromises were made in how the humanitarian actors engaged with people they were seeking to support, and so there was greater distance. And I think I need to caveat this third bullet. I'd say community dissatisfaction with their participation and engagement in the response is something that has been echoed by the IASC, by IASC members, and it's also a fairly common thread in many of the interagency humanitarian evaluations. And we heard the same thing again, fairly consistently. What we heard from communities in these 8 countries that we visited was that oftentimes they're either not aware of how to feedback on their experience of assistance or their specific needs, or they didn't necessarily trust the mechanisms that existed. And I say the caveat with that is obviously it wasn't the humanitarian system in its usual mode. It was in fairness at a sort of distance mode. So to some extent there are some mitigating factors, but I think it's still an important finding, an important moment as well, to reiterate, I guess. And this is where we come to the recommendations in the dark blue box. They're written in shorthand. And I must admit, with the recommendations, we went through quite a journey as an evaluation team, sort of starting off trying to think, well, what needs to change? You know, what are the new recommendations? How can the system shift? And actually where we came back to, and you'll notice this across a number of recommendations, is kind of what I started by saying, less about the need to do new things and different things, but actually more about the need to be cognizant of what we're signed up to do, to look at existing policies, to strengthen monitoring and reporting in order to hold members of the humanitarian system both collectively and individually responsible for them. And on AAP, this is particularly the case, acknowledging that there are now a fairly clear framework for collective accountability. The IASC statement of the principle of the IASC principles is very clear on commitments, and now it's actually really important to move from what we're saying to actually ensure that we implement that consistently. And I think that was one of the key issues that came out of the evaluation, the need to shift from policy to practice. So the second cluster of recommendations, please. So secondly, it is around, again, a sort of extension of the need to put people at the centre of response, need to ensure that we are consistently, that the system is consistently reaching those in greatest need and that are least visible. And whilst we acknowledge, and the evaluation acknowledges, the sort of strenuous efforts that were taken to try and undertake needs assessment, despite the remote nature of many of the methodologies that had to be pursued, we did see that it was very patchy in terms of being able to understand and acknowledge and then program for the differential needs of communities. And so whilst in some contexts we did see some very good practice in terms of trying to understand issues around inclusion and exclusion, trying to understand the differential needs of men, women, elderly, disabled, we would say they were pinpricks of light rather than something that was done more consistently. And obviously with COVID being an accelerant of inequality and marginalisation, it was very clear that there was more and more folks falling through the gaps, and the humanitarian system was quite a blunt instrument in terms of trying to understand that. Again, acknowledging the challenges that there were in terms of access to folks in need of assistance. And again, it's trying to move from having clarity around policies, and we acknowledge that there are a number of policies in place. So by way of recommendations, we're aware of obviously important policies around gender, gender-based violence, around the needs of elderly and disabled. So the policies exist. Again, it's about becoming more comfortable with implementing them. It's about shifting from it being an exceptional issue to it being a kind of business as usual, I suppose. And I would say also there is a secondary issue there, that when agencies, when assessments had flagged these needs, as they sometimes did, then oftentimes, because of the breadth of need, then agencies just didn't have the capacity to meet those specific needs. So again, we appreciate that the system was under stress, but quite clear that being able to have a more nuanced understanding of inequality and then addressing that systematically is really important. I think it's important to say, as part of that, the issue around prioritising and resourcing gender-based violence, given what was already known from the Ebola epidemic response back a few years ago, that we knew that there would be a heightened risk, and there were sort of failures to adequately prioritise that. So I think it's important to learn that lesson and ensure that in future public health responses, and of course responses more broadly, that we do ensure that there's sufficient rather prioritisation of that. Next slide, please. So this really is for us, extremely important issue. And as I said in the sort of preamble, there was significant rhetoric with the COVID-19 response around the important role played by local actors. Guidance, the IASC was very quick to get guidance out, and it looked very promising in terms of what was said, and the platform, as well as the ability of local actors really to make a significant difference. Important to say they did make a significant difference, and we had a lot of discussions with local NGOs, national NGOs, community-based organisations, and communities themselves about the role that they played as frontline responders, and again, sort of documented in the evaluation report. So important to say that local actors did take on additional responsibilities, without doubt. However, in all honesty, with limited resources, limited additional resources. And so linked to that, despite the guidance on duty of care, still a significant disparity in risk exposure between international and local actors. The changes in terms of funding, and I think there was an expectation that if there was going to be changes in funding and power, then this would be the time for it to happen. But in terms of the actual figures, it showed that in the first year there was a shift in funding to some extent. So local actors direct funding shifted up to 3%, which is still obviously extremely small, but then subsequently it actually reduced back to 1.2%. So again, we saw a small uptick, but it's very, very modest given the nature of the frontline work that local actors did. Now, that's obviously essential that that changes. There's obviously lots of issues then around the timeliness of funding, given that it was largely through intermediaries that local actors receive funding, and that has important implications for the timeliness or lack thereof of funding. So important messages around resourcing, around risk, and ultimately around the importance of shifting power, taking power. And I recall a conversation with one of the local partners in Somalia who laughed and said, well, of course there's no change until we start getting money. There's not going to be any change because money is power. And there is some very important lessons there. As an evaluation team, we actually thought that in a way the shift has got to be role modelled and has to come from the donors because of the nature of this exercise, which is focused, obviously, the subject of the evaluations the IASC members. And so we couldn't offer recommendations, but there is a big headline around the need for change in the donor community if this sort of resourcing of local actors and this shift in power is going to happen. We do see some points of light looking at recommendations around the agreements that have been made on intermediaries, and we would push and encourage agencies to take heed of those and to make changes in their own policies. We also think there's scope to review global IASC structures to ensure that they're consistent with commitments to localization. Again, we looked quite significant amount at representation of local actors on both country level, but also regional and global governance bodies, and think there's some important change that can happen there. And ultimately, again, it's back to having the policy on the one hand, but then holding the members of the IASC to account in terms of implementing it. And we think that's really, really important. And then to sort of end on this cluster of recommendations, really the big push and the big need for change around the donors community. Next slide, please. So this is around the systems changing. Again, we were a little bit constrained as an evaluation because our focus was the Global Humanitarian Response Plan. You'll recall that the WHO plan, the Strategic Preparedness and Response Plan, was on one side of that, and the Socio-Economic Response Plan was on the other side. So overall, at a global level, 3 different frameworks. And I think that sort of gives a strong message in a way that really gives evidence that the system is failing to work beyond its silos. Now, what we would say is that whilst there was this kind of siloed approach at the global level, less so at the country level, RCHCs, as I'm sure Merit will speak to, tended to sort of take a more operational perspective and focus on the job in hand. And so there was far greater coherence at a country level, albeit with challenges around this shift from humanitarian to longer term, sort of gaps in the architecture, and as a consequence, kind of recommendations around, I suppose, firstly, really seeking to integrate response frameworks from the get-go. So really the moment at which change should have been role modelled was at the beginning of a response, with a wave of frameworks were able to work together. So the potential there, if not a single framework, then certainly collective outcomes that cut across the silos. But ultimately, there's an important whole of system recommendation which went beyond the scope of this evaluation, but is ultimately going to be essential if change is going to happen. And the final group of recommendations, please, is to learn from COVID-19 adaptations. And again, we can't do justice in a single slide to these, but suffice it to say, as I say, it was a high watermark for innovation and adaptation. There was some absolutely phenomenal work that was done and a lot of lessons. And we heard on so many occasions the phrase of building the aircraft as it was flying. It was literally the IASC members and others were extraordinary in the ways they sought to find innovative solutions to these wicked problems of meeting needs during a very, very difficult and complex response. And of course, it being the largest and most complex response, then it needed a large and complex a set of sort of humanitarian actions. So some adaptations worthy of mention, and there's 5 that we listed on this slide. So certainly, firstly, around cash and voucher assistance, CVA, sorry for that acronym. We did think it was a high watermark for cash and voucher assistance. In a number of countries, there was a general feeling that it had finally reached tipping point. So in a way, I suppose, a positive outcome, unexpected positive outcome of a COVID response is that cash and vouchers really did come into their own. There's probably a bit more work that can be done around ensuring that they are relevant to and accessible to even those marginalised communities. Secondly, lots of work around predictive modelling, and we did see some really interesting and innovative work around that. It felt as if the examples we saw were oftentimes out of kilter with reality, but importantly, it was part of a no regrets approach, which we thought was really important. But we think there's probably more work that can be done to refine those techniques and harness them for humanitarian response in the future. One of the sort of negative or points of caution, I suppose we would stress, is around remote modalities. We thought there was some excellent work on improving remote modalities. What we did think is also important is that there isn't an over-reliance on them. And we did note in 1 or 2 communities, 1 or 2 of our focus countries where we visited, the humanitarian community was almost holding back because it thought, wow, we've got we can do this remotely. And the short answer is you can't do it remotely. Presence and proximity is still incredibly important, particularly in complex environments. And so that's one of the adaptations we would say, actually use it if you need to use it, but don't overuse it. And then the last 2 really are around strengthening preparedness. I think it's fair to say that no one was prepared for the COVID pandemic. No one was prepared to respond at that level. There's a lot of actions that were taken that are very positive, but there is a need to strengthen global governance around the international health system. And specific to the IASC, there's work that can be done around preparedness planning, around learning from the GHRP, and we did produce, the evaluation produced a learning paper on a GHRP. An important message around ensuring that it's more inclusive. And I think, and Mervat mentioned this earlier on, to build on the work that was done around the common services, looking to the future and the potential for similar global humanitarian events, to do more work to ensure that can be mobilised as swiftly as possible. So that's a quick race through the sort of conclusions and recommendations.
Great, thanks a million, Andy, and also Tasneem and the whole evaluation team. This was, quite sobering in many ways, but I really appreciate again the extensive consultations that you have carried out over the course of the year of this evaluation, particularly again the time and again prioritizing, of course, engagement with communities. So it was quite revealing and good to hear that you've reached out and consulted almost 11,000 communities and captured the perception, and that was a key component to craft the findings and the recommendations. So thanks again for highlighting that. Again, although the response wasn't perfect in many ways, it really did lead to saving lives, reducing suffering, and providing again the safety net for millions that you've highlighted also in the report. And thanks also for highlighting the perennial challenge that we face as a system, particularly when it relates to translating policy to practice. And from what you said, Andy, it was clear that the policies exist, the commitments are there, the guidelines, the tools are there, but we're challenged at times, especially in big crises of that magnitude, to look at how we can collectively deliver on these agreed commitments and policies. So, but the good news is, it's interestingly enough, at the end of 2022, when the IASC was formulating its strategic priorities, it is no surprise that AAP, localization, nexus, inclusion were identified as some of the top priorities that the IASC needs to work on, and specifically look at how they can be better operationalized, especially the policies better operationalized in the field. So, Andy, thanks a million again for highlighting these points. And I know we're halfway through the briefing, so maybe I'll just jump straight to Jamil Abdu, who is the CEO of Tamdeen Youth Foundation in Yemen. For the colleagues who have not had the privilege of meeting Jamil has more than 22 years of experience in program and project management in the humanitarian and non-humanitarian fields, including in emergency response, economic recovery, peace building, and development. So Jamil, turning to you, really, it would be really great to hear your perspective as head of a national NGO. What was your experience during the pandemic? What are some of the challenges, opportunities, and lessons that you've experienced firsthand during this difficult period of the response? Over to you, please, Jamil.
Thank you very much for your Mirbat, and thank you for the evaluation team who highlights the most important challenges and recommendations in this response. As most of you know, that Yemen was in crisis, and this is here on the 8th of year. And when COVID-19 pandemic hit Yemen, the situation of the health sector was not that good because the situation on the ground, there is a lot of health facilities are not accessible because it's destroyed because of the war, or the lack of access to these health facilities. Also, we got more than 60% of the health workers who are working, or they don't get their salaries or their incentives. Other hand, that there is a lot of challenges on the health sectors. There is the infrastructures, the supplies. It's too difficult to get supplies, and when the pandemic hit, the health sector was shocked because of the amount of response they are required to do, and the amount of the response they need to do, and the amount of the work they need to be done. There is the lack of access to most of the people to the health facilities. There was difficult, in additional lack of supplies, lack of awareness of the people. People, they don't believe, or they having difficult to absorb the shock of the pandemic. Regarding actually, there was a lot of steps has been taken from either there was, because of the situation in Yemen, there is a lot of collaboration between the Ministry of Public Health, also collaboration between the local NGOs, even the private sector was involved in this pandemic. We face a lot of challenges also with regards to the funding. The funding was too short. Also, the access to provide the health services to people, because there is a lot of people in remote area. The roads, the main roads were blocked because of the conflict, and all these things relate to that. The response at the beginning of the pandemic was too slow, but with the collaboration with other with the key stakeholders, and with the government, with the local NGOs, with UN agencies, the wheel started to roll up, and the response started to get better and better. There is a lot of work, coordination work was done between local governments, local authorities, clusters, also the UN agencies like WHO, UNICEF, regarding the response. The pandemic also create a lot of pressure on the government and also on the local NGOs, because the local NGOs are the first responded on the ground. They are facing the people. There was a lack of funding to the direct funding to the local NGOs. There was no like flexible funding to respond to the pandemic. But despite all these challenges, local NGOs prove that they can do and they can do the actual work on the ground, because what's happened, the culture, they understand the context, they understand the local context, they understand the culture of the people. They try to persuade the people to the importance of the COVID-19 precautions or preventive measures. Also, the importance of vaccination process when the vaccination process was started. So all these things led to quite response, or acceptable to somehow acceptable response to the pandemic. What can be done better? During the response, more coordination involving of the local actors, that will make the response is much better. Also involving trying just putting more flexible funding for the local NGOs, because there is a lot of funding was restriction. There is a restricted funding to the local NGOs, despite they are the first, they know the context, they are on the ground, they are in more contact with the people. So more flexible funding during any pandemic will help these things. Also provide them with the logistic support, because we were in a war, and there is a limited there is a lot of restriction to import the medicines to the country. All of it's done through the UN agencies, and this make it a little bit delayed in some areas. Also, the coordination and communication to the people also could be done better. Management of awareness campaigns, also support the infrastructures of medical sectors, especially in more Yemen has 21 governorates. There is in more than 13 governorates. People, health workers hasn't received their monthly salaries. What they are left on, some incentives, which is not enough for them to respond to their basic needs. So what can we imagine from people? They don't have their basic needs to respond to a pandemic. So I think these things need to be considered in future response to the pandemic. Thank you.
Great, thanks a million, Jamil, and thanks again for sharing a quite important perspective, specifically from Yemen, which is a very particular and unique context, but also from your experience heading, a key local NGO there, in terms of the challenges that you faced as a local NGO, in terms of getting supplies, in terms of getting funding, in terms of, again, giving a visual with regard to the challenges, also with the access to communities, that are affected, by the crisis, the conflict lines that had made access even more difficult, the challenges in terms of also making available salaries for health workers to be able to continue to work and be present at the health centers, amongst many other challenges. Having said that, I was also encouraged to hear again about the resilience and the strength of the local NGOs and the authorities on the ground that continue to deliver despite all of these, challenges. And to your word, it was, overall, an acceptable, level of response despite the constraints. If you don't mind, Jamil, I will turn to you in a minute because there's actually quite an intriguing question from Rachel online around capturing local experience and the realities regarding their cultural and local ways of coping with COVID. And this is something that is, quite an interesting, perspective, because in many of the contexts and many of the countries where we operate, there was, as you mentioned, reservation with regards to taking the COVID vaccine, with regards to awareness that actually there is a public health pandemic that is, at large. And so there are traditional cures, I understand from, again, Rachel was mentioning that there are some local solutions that were considered to address some of these risks and threats. So if there's anything that you might be able to shed light on that, Jamil, from your perspective and your experience in Yemen, that would be brilliant. But we'll circle back to you in a moment after we have had the chance to hear from Mireya and colleagues. Mireya is, once again, is the resident humanitarian coordinator in Colombia. She brings more than 27 years of experience, which she acquired within the UN and externally to the position. At the UN, she most recently served as resident coordinator in Uruguay, and prior to that, she held senior positions with UNDP, including as resident representative in Uruguay. So with that, Mireya, over to you, please, to share also your perspective and experiences from Colombia. Over to you, please.
Thanks, Mervat. We really appreciate the opportunity to have been part of the evaluation, and I think it has forced us also to reflect a lot about what went on. So what I thought I would tell you briefly, it's a little bit about the context in Colombia, not so much the socioeconomic impact, but how COVID intersected with the conflict dynamics in this country. What was the focus of the humanitarian response, and some considerations and lessons from that time. And I do have to start by saying that, like elsewhere in the region in Latin America, the COVID had very harsh socioeconomic consequences. I could give you figures and statistics, but let me just say that the shock of the pandemic undid pretty much 2 decades of socioeconomic progress, and it exacerbated inequality in a country which is already and was already, one of the most unequal countries in the world. And just to say, in 2021, half of the population in Colombia were food insecure to one extent or another. And extreme poverty, not income poverty, but extreme poverty had really gone back to levels of 2004. So just gives you a picture of the size and scope of the impact. I'd like to point out that the closing of schools meant also not only that there was a massive falling behind in fundamental learnings, but also that children lost their protective spaces. We saw an exponential increase in children recruitment by armed groups, as the poorest families could not care for them or needed to rely on them for some extra earnings. And as is the case for all of the complex humanitarian emergencies in the country, Afro-descendant and indigenous communities were hit the hardest. We see that across the board, COVID and any other dynamic. But clearly during COVID, the lack of health services in rural communities in the country's periphery, where the state is most absent, including in places like the Amazonas, meant that we had massive underreporting of COVID cases, but also in those areas, the highest incidence and mortality rates. As the government was shifting resources and presence to combat the pandemic, what we saw was that the armed groups leveraged this absence of the state in the periphery of Colombia, and they were able to consolidate their control over very vast territories. And I have to say that much of the access that was lost then, we haven't yet recovered. The state has not yet recovered. And the fact that we couldn't move because of COVID, that the humanitarian community and the public services were not reaching these regions, also meant that the type of control that these groups were exercising over the population became a lot stronger. I mean, they had additional mobility restrictions, They had often to stay in confinement. They had social rules that were imposed as to what they could do and could not do. And worst of all this harassment and additional control went very invisible. And finally, the pandemic and its impact clearly had a particular negative impact on youth. And this acted as a catalyst for social protests in Colombia. Some of these protests had already started prior to COVID, but a proposed tax reform in 2021 ignited what became the largest and longest protest in the history of the country. So voila, you had death, you had poverty, you had learning losses, you had child recruitment spiking, you had an actual expansion of non-state groups controlling more territory and controlling more people. And on top of that, you had these massive protests. A rather perfect storm in a country that otherwise is an OECD member, Now, in terms of the response, and let me start also by saying that this was clearly a government-led response. I mean, this is a middle-income country, and they did three things that I think were very much in the right direction. They did act rapidly. They had a very strict lockdown, which was economically difficult to handle, but it was important to mitigate the spread of COVID. And they used those 5 months to really double their ICU capacities. So this is a country that did not see its health system collapse, even though it's fair to say that the furthest away from the bigger cities, that presence of the system and the weakness of the system would be more felt. And now on the economic front, they enhanced the social safety nets coverage, and they actually reached almost 3 million poor and vulnerable households with a one-time basic income. And the third thing they did very right is that they took the decision, and this was a bit later on in 2021, early on, to grant temporary protection to 1.8 million Venezuelan migrants and refugees. And in effect, in doing so, they grant them, they regularize them, and they grant them access to social protection, including healthcare. So, from a state, a very proactive, not complete, but a very proactive and early action on several fronts. Now, on the humanitarian side of things, what we focused was essentially 2 things, and I'm generalizing a bit, but it was food assistance. You mentioned what was the impact and the constraints that were faced in supply chains, especially in urban centers, again, compounded by those social protests that resulted in a lot of blockades, but also supporting basically health services and vaccination. And we did so among the most left behind. I'm referring to the rural areas, to the indigenous communities, and to the migrants. Now, in Colombia, there is a dual humanitarian structure, one that supports Venezuelan migrants and refugees, and the HCT, the humanitarian country team that services basically everybody else. And they both issued plans, COVID plans. In the case of the humanitarian country team, there was a request for 284 million to reach 1.3 million people. The Response for Venezuela platform had its own plan for 297 million to cover the needs of 2.3 million refugees and migrants. Unfortunately, I have to say that, for instance, in the case of the HRP, we only were able to secure about 12% of what we asked. Now, Colombia, as I said, was able to rapidly scale up vaccination campaigns, and they did focus on rural areas because it was there where the most infectious variants were advancing. And also because those were the areas where there was less capacity in terms of the health systems and less ability to reach with the social safety net system. So vaccination in itself became the way and the response of the state in those territories. So we did, I think, play an important role, the international and local humanitarian partners, in ensuring that vaccination could be rolled out in the rural and hard to reach parts of the state. For instance, following a very strong surge in COVID cases that was observed in the very remote Amazonas region, in the border with Peru, Colombia, and Brazil, we use 2020 self-funded allocation to enable humanitarian actions to pretty much enter those territories where we had close to non-presence and operational capacity. And these initial investments that we came with provided the Colombian share of what became a trinational response plan in the Amazonas. And so we were able to provide food, health, hygiene, and also be there and offer protecting mechanisms for these communities, including, as I was saying, preventing the recruitment of some indigenous children. Not only we were able to reach these very remote areas, but we were also able to include the Venezuelans in the national vaccination program. And I'm saying that because even though they were granted the protection status and on paper they were able to access social protection like everybody else, in effect, that process took some time. So in the meantime, there was a lot of advocacy and political capital used, not only by those working in the migration and refugee agenda, but in general by the country team to ensure that, Venezuelans, any other nationalities, including pendular movements, there is a huge numbers of Venezuelans that come pretty much for the day, either to go to school or to precisely access health services. Those, even though they were not part of the protection scheme, they were also vaccinated and offer assistance. So I think it was a great show of solidarity to a neighborhood country that was really struggling. And now to close, and I'm going to try to be a bit telegraphic, but some of the considerations, and they're not unlike the ones that Andy alluded to. I mean, on the brighter side, some of the work that we did with COVID, and I was giving the example of the Amazonas, really allowed us to come and land in territories and in parts of the country that were hard to reach and where we didn't have an operational capacity. And so we were not only providing COVID, but other health response. We had health brigades with WHO arriving and starting to provide, care against violence, against other diseases. We were able to establish more protection systems, and in some cases, safe spaces for women, for instance. And so we were very, very, very conscious that we needed to look at the intersection, as I was saying, of COVID with education, with violence, with other protection risks. And so it was on those places where we could see this happening that we tried to be more present. One of the very hard learned lessons is how difficult it is to reestablish oneself after you have left the territory. And it's not that we left because we wanted to leave, is that since the signature of the peace agreement in Colombia in 2016, particularly the non-Venezuelan related humanitarian team has really been shrinking. There's been a perception that we would not be needed. There were questions about OCHA staying or not. At one point, the figure of the humanitarian coordinator was done away with by the government. And we lost the country-based pool fund in 2020. So from that was all the parting point, and that's from where we had to respond to COVID. And no wonder we got 12% in our appeal, because that's part of a process that was going downhill in terms of our ability to make a case for humanitarian work. There was a good level of articulation, and despite the silos that did exist globally in terms of the planning response, and that happened both in terms of these two humanitarian platforms, the Venezuelan and everybody else, but also with the government. I mean, the health sector is the only humanitarian cluster that's co-chaired by the Ministry of Health. And it made, I know that sometimes gets some partners to raise their eyebrows, but I think it was fundamental to what we did then and to what we're continuing to do now. Just to second, without getting into the details, that we could see firsthand how resilient the humanitarian community was. We adapted to remote working where we could. I mean, again, there are big parts of the country where access remains a challenge. And we were able to maintain a significant level of needs assessment during that whole period. And clearly all of that dependent on these local partners that we had been working with, and that made all the difference. To final comment, I think some of the things that I see as humanitarian coordinator that have permeated our way of thinking, there are probably many, and clearly the issues of localization we are a flagship country, so these issues we're going to be structurally bringing them forward. But I wanted to raise two. One is the indigenous dynamic, and it has to do with the question that was raised. When we landed in the Amazonas, we didn't speak the languages, we didn't know the cultural practices, and we had to go there with anthropologists and with people that could help us, understand what their needs were in a very different way than everywhere else in the country. And from there, we have since designed a strategy on engagement, on humanitarian engagement with indigenous communities, which we recently launched, because we're very conscious that the learning curve in terms of how we interact with our communities who have concepts of self-care and of relationships with the environment that are fundamentally different than ours. There is mindset we need to learn, starting to learn to listen. And I think that's a route, a no-return route that we have taken in terms of nuancing the way we work. Second one is on mental health. I think COVID in general opened up, not in the case of the humanitarian space only, but it has taken mental health issues out of the box. And we know now that mental health will have to be COVID or no COVID, particularly for these communities that are under tremendous stress for armed groups and other disasters. It will have to be part of the package that we offer. So we see that, and we're starting to make investments in mental health that we hadn't done before. And my last comment is that at the end of the day, if I go back to the original question, if another pandemic was to strike next week, would we be better off? And I think that ultimately there is no substitute for what the state has to do. And in that sense, I would like to signal the efforts that the current government, which took place after the pandemic, is doing in terms of really mobilizing a universal basic income scheme, continuing and keeping their commitments. This is a different government now on the regularization of migrants so that they really fall under the spectrum of the social protection schemes of the state, and a health reform that's now in Congress that would really, really look at ensuring that there is health coverage in all these parts of the country where there is no system. So that's the best guarantee towards the country being ready. But having said that, the big elephant in the room in Colombia remains, that close to 7 million people live under the control, to some extent or another, of armed groups. Yeah. And that's a much bigger agenda that requires the state to really expand its presence, not only health, but likewise. So I'll stop there. Sorry for the extension.
No, Khalis, thanks so much, Maria. Very rich and multifaceted also response and visual of the response in Colombia. And thanks again for highlighting the protection concerns and also the importance of mental health and psychosocial support that really featured very strongly during the COVID response, and also as a result is featuring as a priority in an area of concern for the IASC in its response in various contexts. And really also great to hear about the good example of how the government of Colombia has really taking the lead. So it was important to see an example of a government, of course, and its leadership role to address the crisis, including in terms of expanding social safety nets, but also expanding the support and social protection to migrants and refugees. Really great examples to have shared. I'm mindful that we have 2 minutes, and I know these were really, really important and rich interventions. So if you don't mind, we have a few questions, and I will take this as an opportunity for whoever I turn to in the panel to perhaps respond to the question, to maybe use that as the closing remarks, because I know colleagues will have to leave on the hour. So first, Mireille, thanks so much for attempting to address to a certain extent Rachel's comment on traditional medicine. I know it wasn't a head-on response, but it's definitely something worth consideration, and maybe also WHO. Too bad that we don't have WHO colleagues on the panel that could also share some insights, and if there's any research on traditional medicine that could have been used to respond to the pandemic. But any thoughts, Rachel, that you can share also in the chat box would be extremely helpful. Maybe just turning, very quickly. I mean, Kelly, David, you're online, or Andy. Just a question from Igarachi regarding the possibility of having particular protocols for coordinated planning for pandemic and public health crises. I know in the IASC, the scale-up protocols were adapted to respond to the COVID, so it's not the classic scale-up protocols. These are the system-wide emergency activation procedures, and we have adapted them to respond to the COVID. So maybe again, Igarachi, this is what you're referring to. You can find these protocols online, but Kelly and Andy, if there's any additional insights or feedback that you can provide to respond to that question, would be welcome. And then maybe Turning to Jamil and Maria very, very briefly, just to also share any experience or visual with regards to any evidence of self-initiated coordination among local actors. So beyond the international humanitarian coordination, which in some cases worked to a certain extent, and in some cases didn't work very well, is there any evidence or good examples of self-initiated coordination among local actors that you can also share with the audience? And we will stop here. I'm sorry, colleagues, I know we're already at the hour, but very, very brief remarks or reactions to these questions, and then we will conclude. So over to you, Andy, Tasneem.
Yeah, I think we better use
please.
the last moments for Andy to be able
Thank
to
you.
speak, since he
Thank you.
led this exercise. Thank you.
Thanks, Kelly. Thanks.
Thanks very much, Merva. On the sort of preparedness and protocols, we thought the scale-up protocols were extremely useful and well thought through. We think there's 2 or 3 different types, so there is scope, we would say, to use some of the learning to perhaps sort of revise and consolidate those protocols. On preparedness, probably also important to note that the emergency response, the ERP at a country level, so the preparedness document that's held, really didn't cover sort of these public health emergencies. So certainly scope also to look at how to strengthen that from a country perspective, acknowledging that that's where the rubber hits the road. And so really important that is fit for purpose, given the knowledge we now have about these pandemics, epidemics, public health crises. So there's a short note on that. Thank you.
Perfect. I think
You're on mute, Mervat.
Sorry, just a huge thanks to Andy and Tasneem and also to Kelly, but maybe turning very briefly also to Jamil, and we'll conclude with Maria. Over to you, Jamil.
Thank you very much. We in Yemen, we got this experience and local mechanism for coordination. When the pandemic hit, we did like a coordination, a lead of Temdeen as a lead of localization initiative at that time, and we are leading some. We did the coordination with the governments, international NGOs, also with private sectors. And we success to convince the private sector to interfere and to contribute to the response of the COVID-19. Also, the private sector provided a lot of medicine, also the equipment required for responding to the COVID, and also in supporting the intensive care units in some hospitals which fighting the COVID. Thank you.
Super. Thanks a million again, Jamil, for your interventions, and turning briefly back to Maria again.
Thanks. No, just to say that on the issue of local humanitarian partners, I mean, if there is a country where there is a richness of civil society, this is Colombia. Our humanitarian country team has more than 100 members, and the response for Venezuela has another 60, 70 members. So already within the scope of what we are more directly involved, we have a huge representation. In addition to that, we have humanitarian coordination spaces locally that are autonomous from us. Even though I have to say they're not strictly humanitarian, they're also much related to the peace agenda and to participation. And that sometimes gets in trouble because we mix the political process. But just to say that this is one of the areas where, in the context of the flagship, we're going to be really looking at reestablishing funds that can be dedicated strictly to them. We're mapping those local capacities. We got about 100,000 local organizations. So, you know, it's not the offering, it's more how do we make the mechanisms allow the channeling of resources and a degree of joint purpose in what we're trying to do. But there is a very, very fertile ground. Super.
Thanks a million, Maria. And maybe just to give the last word to Kelly, and then I'll make a short announcement on the upcoming briefings, IC briefings that are coming up, but over briefly also to Kelly. Thanks, Kelly, for your patience.
Again, I'll just say thank you, as everyone echo the thanks to Andy and Tasneem, working on what has been the broadest in scope and challenging evaluation as the COVID response was itself for our group. And to note that we are continuing as some of you may not know, but we do these interagency evaluations for all scaled up responses. So just for you to know that we are ongoing doing a IAHE, a similar evaluation of the response in Afghanistan, as well as to the Tigray crisis in northern Ethiopia. We are planning the interagency evaluation of the collective response in Ukraine. And of course, we'll also have to consider one for Somalia because that was also declared a scale up, as well as looking at a number of thematic evaluation topics along the line, probably looking at either AAP or localization. And the Emergency Directors Group has asked us to do a specific review of the scale up mechanism itself, because as you can see, we are now having an unprecedented number of simultaneous scale ups, which is a very big stress on the system. And so it's a look at how this is working for us to lead to better response. So we'll use Ethiopia and Afghanistan as a case study, as well as the body of work that we have from other IAHEs, including this one that Andy and Tasneem has done. So you'll be hearing more about those from us and via Mervat and the IASC. So thank you, everybody, for coming.
Thanks again. Thanks, Kelly. A busy period coming up, and thanks again for your leadership of the IHE steering group. And we look forward to working with you to also translate some of these important, findings and recommendations to actual changes in the system. So, colleagues, just for your information, inshallah, the next IAC briefing will take place on the 2nd of May, and we will have the chance to discuss mental health and psychosocial support efforts, great work done by the MHBSS reference group, and much more to follow on AAP and localization on the nexus, as well as has been highlighted in this review. Thanks again, Andy. Thanks, Tasneem. Thanks, Jamil. Thanks, Mireya and Kelly, so much, and for all of the colleagues that were able to join us today. Ramadan Kareem for those who are celebrating, and happy Easter for those also who are celebrating Easter, and inshallah we'll be in touch. Good afternoon and good evening to everyone.
Thank you.
Thank you very much.
Thank you.